Right, we will go ahead and get started. So today for Grand Rounds, we have with us Dr. Cook. Dr. Cook is a licensed clinical psychologist specializing in trauma and suicide. She earned her PhD in clinical psychology from the University of Utah and completed her residency at Salt Lake City VA Medical Center. She currently works as a staff psychologist in the ambulatory psychology clinic within the Providence Healthcare System in Washington State, where she works closely with one of our previous graduates, Dr. Eric Demaray. Throughout her training and career, Dr. Cook has focused both her research and practice on suicide prevention, intervention, and postvention. She's here with us today to talk about provider postvention for individual providers after losing patients to suicide. And now I will turn things over to Dr. Cook.
Thank you. Good morning or good afternoon for you all. Still barely 9 a.m. here. Let me get my window shared. Okay, you should be able to see it. Looks like now. Awesome. So today we're going to be talking about suicide, but we're going to be talking about suicide on the back end after suicide has already happened, which seems to be, the least common way that we talk about suicide. And let me see here. Oh, it won't let me share in big screen. Is it showing you little slides or does it take your whole window right now?
It's just showing little slides right now.
Let's see. Well, let's try this.
Will it let you go to slideshow?
No, it just has it grayed out. Like I can't share the slideshow when I'm sharing my window with you, but I bet I can share the entire screen. So let's try that. You'll see yourselves for a brief minute. Sorry, I know it's always awkward staring at your own faces. Okay, now let's see. Okay, let's try it up here. Not now. Okay, that should be better. How's that looking on your end?
It looks good, but we see like the notes present.
Okay, let's try it like this. Let's see. I wonder why I can't just, what if I move this out of that way? Okay, now?
Still seeing notes view.
You can do display settings. Go to display settings right there at the top.
Yeah.
Swap presenter view and slide view.
Okay, there we go. How's it looking now?
Perfect.
Thanks. Technology is not my forte. Okay, so today we're going to talk about suicide postvention. So what do we do after patients have died by suicide? And before I jump into the slides, I'd like to kind of just read the room a little bit. So when you're sitting here, hearing and thinking about, okay, we're talking about patients killing themselves today, what are your initial gut reactions or thoughts or emotions that come up? Feel free to unmute and throw them out, or you can type them in the chat. Maybe if someone will just unmute and moderate the chat for me since I can't see it anymore.
So Dr. Smith wrote sad in chat. I echo that. I think it's if you think about the kinds of things you're trying to help patients mitigate is certainly self-harm and those, it's sort of the worst outcome of our patients in a sense. And it's always hard to, when you're doing all the things you can to accept that, in spite of, sometimes people do commit suicide.
Yeah, absolutely. Yep. Yeah. What are the thoughts when you think about your patients dying by suicide? What comes up? Sadness.
Let's see, Dr. Lee in the chat. Guilt is not quite the right word, but fears that maybe I didn't do all that I could have.
Right. Yeah, absolutely. Yeah. There's a whole variety of things, and you're already touching on several of them that we've talked about just in the last 30 seconds or so, but there's a whole variety of things that come up when we think about and talk about our patients dying by suicide. Lots of the fear, some of the self-doubt. Did I do enough? did I do the things that I was supposed to be doing? Is there more that I could have been done? Did I miss something along the way? Will the patient's family blame me is something that I hear often. What will the patient's family think? They were actively involved in mental health treatment and they still killed themselves. What will the family think of that? Will they think it's my fault? Will I be in trouble, whether at work or, malpractice things, or what legal ramifications could be involved? Sometimes there's investigations that are involved after a patient dies by suicide. So there's a lot of these things in the mix around suicide postvention. And I think that's part of the reason that we don't talk a lot about our patients dying and what we do when patients die, because of some of these things that kind of get in the way of us doing that. So let me give you a little bit more of my background, just at least as it relates to suicide. So I was trained in a national suicide lab all throughout my training, which means that if a patient wasn't imminently suicidal, I wasn't seeing them. So I'm trained and experienced in almost all of the evidence-based treatments you can think of for suicide that exist. And again, if a patient wasn't pretty seriously suicidal, I wasn't seeing them. Even as a trainee, I was only seeing suicidal folks as a specialty. So over these years, throughout this time, I did a lot of research on suicide, published a lot of that research on suicide risk and prevention and intervention. On my residency, I worked on a specialized team for the VA, which is called the SP 2.0 team. If you're not familiar with it, it's like a suicide specialty team. It's a nationwide team. So we providers were scattered across the whole country, and we saw patients across the whole country virtually. And in order for a patient to be seen by our team, they had to have a pretty serious suicide attempt or some kind of suicidal behavior within the last 12 months. So the most suicidal people are the folks who we were seeing on that team. And then I also was on the VA Suicide Prevention Oversight Committee. And what that committee did is we reviewed the deaths of patients after they died by suicide in our VISN or in our region. So a patient would die by suicide, we would get a notification to the committee, and then we would meet monthly and review all of the suicides that had happened in our area, in our big area during that month. We would kind of comb through the medical records, see what was going on in treatment or, not in treatment, and did providers miss things, or could something more have been done? And the aim of this committee wasn't like a gotcha for providers. It was more to identify on the system level, are we missing things? Like, are there better practices we could implement or things we could try to prevent more suicides in our system? And then we would take that information and the results from our review of the suicide death, and we would go back to the provider or to the clinics and kind of provide just training and education for new things that we can do based on things we had missed in the past after patients died by suicide. So you would think all of these things would have prepared me to cope with my own patient suicide loss, right? Like, suicide is my thing. It's what I had done pretty exclusively for many years. But really, when my patients started dying by suicide, I was not prepared despite that. And as I look back, retrospectively now on my training, we talked a ton about suicide prevention. We talked a ton about suicide intervention, but we never really talked about postvention, about how providers or clinics or families or communities are impacted by suicide after it happens, or what do we do about it after it happens. So my personal history, I have lost 2 patients to suicide, and they were kind of back to back within 6 months of each other on my residency year at that Salt Lake VA hospital that I was working at. Notification and response was pretty poor from those around me. And I want to be clear, it was really well-intentioned. People cared. They cared a ton. And there's just such little education and preparation in this area that it was pretty poor. So my first patient, I found out that he died through one of those Suicide Prevention Oversight Committee emails. I opened an email of a patient suicide that I was supposed to review, for our next meeting where we would kind of go through the medical record. And I opened it up and it was my patient. And it was, ironically, the chair of this suicide committee that I was on was also my supervisor for that patient. So it was a pretty big oversight that I had found out via email.
Not gonna let anyone go through it. I don't care what you're doing.
Yeah, pretty big oversight on that one. So the second one, similarly, I found out just by opening the medical record, which your system probably has something similar. If you open the medical record, there's some kind of death notification that pops up after patients have died. And so that was how I found out about the second one. Response from everyone, as I mentioned, was really well intentioned after my patients died by suicide, and there was a lot of variation. I had colleagues and supervisors and mentors on one end of the spectrum who wanted to talk me to death about it, wanted to meet every day, talk through it over and over again, process it to the point where I just was feeling way suffocated and overwhelmed and just tired of talking about it, all the way to the other side of that spectrum where some of my friends and colleagues and my mentors and supervisors were actually avoiding me because they were so uncomfortable and like didn't know what to say or what to do. So they just kind of avoided the topic. So I tell you all this not to overshare, but more so, I guess, to normalize a couple things. First of all, our patients die by suicide, and that's a normal thing. It's not something that we talk about very often, but even the most prepared providers who are fantastic providers, competent, even suicide experts, lose people to suicide. So I want to normalize that, we have some degree of control over our work and what we do, but largely our patients decide what they do in their lives. And so, it happens. The second thing is it's okay to talk about it. I think there's a lot of stigma within our field, even where, we don't talk about losing patients to suicide, not with supervisors, not with colleagues. It's just kind of more of a private process, it seems. And so I tell you those things not to overshare, but just to normalize. Like, it happens, it sucks a lot, and it's okay, it's normal, and it's probably healthy and a good thing for us as providers to talk about these things that happen in the field. So that intro aside, let's talk about some of the numbers around suicide and what it's looking like for us in our field. So broadly in the United States, rates of suicide deaths and attempts and self-harm have all increased in recent years, and really recent decades have been rising steadily. Suicide is currently the 11th leading cause of death in the United States. And the most recent CDC data that we have is from 2022, is the most recent complete year that's published. And we had about 50,000 suicide deaths in the United States during that year, and about 1.6 million attempts. Now, keep in mind that these are probably pretty gross underestimates, given that, there's a lot of unreported cases or misidentified cases of suicide, like the case of accidental overdose. We don't really know if it's accidental or not. And certainly a portion of accidental overdose deaths likely are not accidental. So this is what we've got, probably an underestimate, but still some pretty big numbers. Who specifically is dying by suicide? Men die by suicide almost 4 times more often than women do. But on the flip side, women actually attempt suicide way more commonly than men. And kind of the differentiating factor here that we see in the literature is that men tend to choose more lethal means for suicide, and that's likely why they die at higher rates than women do, whereas women tend to choose less lethal methods for suicide, things like cutting or overdose on less lethal types of medications, and men are often choosing like firearms are the number one method there. As far as demographics, right now, about 70%, almost 70% of suicide deaths are among white males. That isn't to mean that other nationalities or intersecting identities aren't at higher risk, because there's a lot of pockets of people who are at higher risk for suicide. But currently in our country, we're looking at a lot of white males who are dying by suicide, and 55% of that time it's by firearm. Often after that, we have things like the next common one is overdose, and then types of like asphyxiation or hanging after that. And then there's a whole slew of other creative categories of ways that people attempt and die by suicide after that. So unfortunately, I recall that many of you work with, pediatrics and adolescents as well. And this suicide problem isn't just a problem for adult patients either. In Kentucky, suicide is actually the second leading cause of death for youth in Kentucky. And the Kentucky Department of Education actually recently has sunk a lot of money into research on suicide. And they published some stuff recently saying 15% of Kentucky high school students report having seriously contemplated suicide just in the past year alone. And then 17.5% of middle schoolers report having seriously considered suicide at some point in their life. So I don't know exactly what middle school is in Kentucky. I imagine it's like 6th, 7th, and 8th, or 7th and 8th. But either way, at that stat, we're looking at kids possibly as young as like 12 years old who are retroactively saying, yeah, I've considered it seriously at some point before in my life, before age 12 years old when they were entering the middle school range. So it's definitely, common among adults, certainly, but an issue that we see in pediatrics and youth as well, especially as media exposure to different suicide things increases. We kind of see little spikes in youth suicide as well. So what does suicide look like in our healthcare system? And this isn't specific to my healthcare system or to yours. This is just national data that's been published on what suicide is looking like across big healthcare systems in our country. And most patients, truly almost 100% of patients, had some kind of services in a year prior to a suicide attempt or event of some kind. So 73% of them were actually even seen by outpatient behavioral health. 90% of people had some kind of medical appointment that they went to in the past year before they died by suicide. 69% were seen in EDs in the year before they died, and then 42% were seen on inpatient units before they died. So utilization is high in the past year before suicide death, but it's also really high even in like the days and weeks before people die by suicide. So in the 30 days prior to a suicide death, 69% of people are utilizing one or more of these things up top that I just went through. So they're going to at least one appointment in one of these settings, but oftentimes more than one appointment in more than one setting in the 30 days prior to suicide. By far, outpatient services are the most common contact point, 94% of these events being seen in some kind of outpatient setting versus 69 showing up in the ED and 42 in the IPU. So we, those of us who operate in the outpatient realm, are the most likely providers to encounter patients days and weeks before they end up dying by suicide. So who, though, like among us, who are the providers that lose patients? This is still really, really new research. It's fascinating if you're ever bored in Googling. But it looks like, estimates vary really widely, but it looks like at least 1 in 4 of us will lose a patient to suicide at some point in our career. And the estimates I've seen go up to 85% in the literature, but I put this range of 25 to 60% because those seem to be the most consistent estimates that I'm seeing in the literature. But one did say as much as 85% for psychiatrists in particular. Again, take this for what it is because it's emerging research, and so still lots more to learn and know about this. But at this time, it looks that psychiatrists are at a little bit higher risk to lose patients to suicide. But everybody else is also at very high risk, all the way from master's level, social workers and therapists to psychologists to psychiatrists, to APRNs, kind of anyone in this behavioral health world that we work in. Even if you haven't lost a patient to suicide, or let's say, we have a crystal ball and you never will lose a patient to suicide, all of us manage suicidal patients. I put almost because I guess I can't know for sure that none of you have never managed someone who's suicidal. But my guess would be if I asked everyone, raise your hand if you have never seen a patient who has thought about suicide before, that probably no hands would go up. The most likely scenario is that all of us have encountered probably many patients who have thought about or are thinking about suicide. So one thing that is a bummer and kind of creates more stress for us as providers in this area is that the reality that suicide prediction is poor. We have many, many decades of really great, cool suicide research, and we still know very little about who is going to die by suicide and when they're going to die by suicide. So that prediction difficulty creates a lot of problems for us when we're managing suicidal patients, right? Sometimes we have patients who are seemingly so imminently suicidal that we're really freaked out or concerned that, an attempt could be looming. And then other times, sometimes we have patients who make attempts that we weren't actually that concerned about because they didn't seem like they were that suicidal. So it can be really difficult to predict who's at the most risk and when they're at the most risk. And that unpredictable nature of managing suicidal patients can really make us feel helpless as providers, or like we have a lack of control over what happens as providers. So it can definitely kind of take a toll professionally. When we do lose patients to suicide, there's a number of what the literature calls major emotional reactions that happen after our patients die by suicide. Unsurprisingly, probably you'll read through these things: fear, guilt, anxiety, self-doubt, hopelessness, frustration, anger. They make sense, right? I don't imagine we'll be shocked at any of these things that are on this slide here. But research shows us that almost all providers have at least one, but usually multiple major emotional reactions. The most common I've listed down there, including shock, betrayal, and the ones we just read. But the reality is, even the most prepared providers, the most emotionally controlled providers, whatever you want to label it, also have big emotional reactions to patient death. So it's unlikely that a patient dies and a provider just has no response or feels okay about it. So after we lose patients to suicide, there is a fair amount of research in this area. What do providers do after that as far as their work life? And many providers actually don't want to manage suicidal patients anymore, and they become quite avoidant of these patients, even if they're still actively seeing these patients. Providers report having less positive feelings and more negative feelings towards suicidal patients. They report feeling more overwhelmed in their work, more distressed, and then, like I said, avoidant of the patients, which is kind of a catch-22, being avoidant of the patients who likely need the most care, right? But you can imagine with these major emotional reactions going on, there's a lot of fear and unease at interacting with and trying to provide care for suicidal patients right after you've experienced a suicide of one of yours. There's also pretty high rates of depression, like diagnosable depressive disorders among providers after patients die by suicide, as well as vicarious trauma that happens after a patient has taken their life as well. So what do we do about it? There's a lot of things to be done about it. These are kind of broader postvention strategies that are things we think about a little bit more on like a clinic or unit-wide level, but I'll go through them briefly and then we'll kind of narrow it down and talk more specifically. You sitting here today, what do you do to prepare for or kind of process through this? So on the broader level, research tells us that how clinicians are notified matters a lot. Kind of like I said earlier, right? Both of my patients that died by suicide, like I found out by accident. I got an email to review something for a committee I was on, and it was my patient that was dead. No one had told me that prior to that point. So notification matters for providers. Be quick at notifying people, be direct, don't beat around the bush, don't use tentative language, be quick, be direct, and be sensitive to individual differences, meaning, like I said earlier, some people really want to talk and over talk about it, and then some people don't want to talk about it at all. And so kind of being sensitive and sliding that spectrum back and forth based on where your provider's at in the moment. The research suggests giving providers the option to review the case with an internal or an external consultant, letting them pick between the two. There can be a lot of fear in reviewing cases with internal consultants or peers or supervisors, just because of that first slide we talked about, some of the fear of like guilt or blame or being judged, or, like having investigations that might happen or fault being found on your end. So a lot of providers after suicide reported feeling uncomfortable talking through the specifics with their colleagues. And that's where the external consultant can be helpful. This is a good processing point for the provider, but it can also give the clinic some good data of kind of like the committee I served on. Was there something missed? I know that we do the best we can as providers, but are there areas we could improve for next time, and kind of thinking through those things when the time is right to do so. Psychoeducation is important for providers and the clinic at large on the normal sequelae of suicide loss. So again, a lot of what we're talking about today, right? Like normalizing, like patients die by suicide. It is a thing. It happens, and it happens pretty commonly. It sucks. There's these awful reactions we have to it, and here's what we can do about it. Just kind of giving, some normalization and some information behind what it looks like to have patients die by suicide can be a helpful thing for clinics after a patient has died by suicide. And then the same thing with education afterwards. So remember, providers that kind of fear or uncertainty about like managing suicidal patients after a suicide extends to colleagues too. It's not just the provider who lost a patient that no longer wants to manage suicidal patients. Even the people around them can get a little bit freaked out and concerned. And so the literature says that it's quite helpful to, bring in people to do more suicide trainings or, like specific interventions or, things that could help providers kind of regain a sense of competency and some kind of control around both suicide risk identification. How do you identify people that are at a quite higher risk for suicide? And then what do you do about it on the other side of it too? So for individual providers, though, here's what I would recommend. The Rocky Mountain MyRec made this fantastic suicide postvention preparation plan, and the PDF, a blank PDF of it, was attached to the Zoom invite, I think. So you should be able to pull it down from there if you want to follow along on your end, or even fill it out as we go. You're welcome to. The idea behind this postvention preparation plan is to kind of safety plan for yourself ahead of time, because when you lose a patient to suicide, your frontal lobe becomes essentially useless when you're in shock and you're grieving, and there's administrative things that need to be done and a lot of major emotional reactions happening. The frontal lobe is like kind of hard to access. It's not firing on all cylinders like it typically would. So this safety plan kind of does the heavy cognitive lifting for yourself ahead of time before you get there. So let's go through it. There are a number of contacts that are identified on this safety plan, and you're going to want to put like supervisors on there that can provide different kinds of support. So after a patient dies by suicide, there are institutional things that need to happen, right? The suicide is reported, there may be some kind of review or investigation that happens. So putting down the contact information of supervisors that can provide that administrative support, and also just emotional support as a colleague or a mentor as well. Putting mentors or peers down, and I added this part, who get it, people who get it. For me personally, and this may be specific to my response after I lost patients to suicide, but I remember feeling like people were really well-intentioned and I knew that they cared and wanted to help. And I remember thinking like there was a disconnect, like they didn't get it though, because the people, my people at the time, none of them had lost patients to suicide themselves. And so I remember just feeling like, even in conversations, there was a little bit of a disconnect, like they couldn't quite understand like where I was at or what I was thinking or saying or feeling. And so, it's great to consult with colleagues. And I would say maybe find someone who's been in that boat before, who's lost a patient to suicide, and just say, hey, hope I never have to, but can I give you a call if I needed to at some point? People who have been there and who get it. Trusted friends and loved ones, of course, on the list that you can call. And then the last thing I would recommend is a therapist and your EAP contact information. Plan this out even if you don't have a therapist. I wasn't seeing a therapist when my patients died. I never did after. I haven't seen a therapist since then. But 2 days after that second suicide loss, I filled out my own postvention plan. And I did the heavy lifting ahead of time for the next time, where you find a therapist who takes your insurance, who is, trained in the way that you would want a therapist of yours to be trained in. Think about how much work it is right now to find a provider, calling your insurance, seeing who's in network, who's out of network, who's taking patients, who's not, whether you need a referral or not, what your copay would or wouldn't look like, if it's virtual or in person, how long the wait list is. I mean, there's a million cognitive tasks involved in just finding a therapist. And your brain, after a patient has died by suicide, is not going to be up for the task. So I would say plan this out in advance. I've had a therapist's name on my plan and phone number for several years now. Never spoken to her before. She has no idea who I am, no idea that she's on my list. But if I find myself in that boat again, where I have got that acute kind of shock and grief, I already have a plan. My brain doesn't have to do any heavy lifting. I can call the therapist and see when I can get in to kind of chat through things. The next part of the plan is different self-care strategies. And these are going to look really different for everyone. This is an actual screenshot from my postvention plan, the one that I made 2 days after my second patient had died by suicide. And the idea here is the same thing. Write them down, even if you think you're going to remember and know what to do, during this kind of acute grief and shock. Because I promise you, your frontal lobe is going to just go right offline for you. And it's gonna be kind of brain foggy for a little while afterwards. So write these things down, have a plan, take that burden off of your brain, and kind of have a list of things you can do to kind of give yourself a boost, or get your foundational needs met, kind of pull yourself slowly up out of the rut over time. So as you look at this, what are some examples? I've got a bunch of things here that I like and I do in my life, but what are some examples running through your minds? What are things that you like to do, big or small, just to make yourself feel a little bit better when you're struggling?
I think for me, getting in nature, take a hike, get out in the path,
Yeah,
work, get out in the park, go get lost somewhere.
yeah, absolutely. What else? And I still can't see the chat either. So if there are things in the chat, if someone would read them for me, I'd appreciate it.
I think just spending, oh, go ahead, Dr. Peters.
Oh, I was just going to say the group's obviously communicating silence, meditative silence as a response.
Yes, that's what I assumed.
I was just going to say, like, spending time with friends and family and loved ones, like you already talked about.
Yeah, absolutely. Yeah. So, take a minute to think about it while you've got your frontal lobe fully functioning, and, jot a few things down. What are the things that help you just kind of keep your head above water when the waters are stormy? All right, the next section on this postvention plan, they call it the realistic self-statement. I think of it as like a mantra, so to speak. It's something that you're going to kind of recite to yourself when you're in this acute grief and shock after a patient has died. The idea is to write a statement that helps yourself cope and regulate ahead of time. It's like past you helping future you remember and regulate in the ways that you would want to if your frontal lobe was fully functioning. So this is my statement that I wrote, again, just a couple days after my second patient had died by suicide. This sucks. It's really sad that my patient died. I want to remember that I actually don't have control over what my patients do, though. And I believe in a person's autonomy to choose life or death, even if that choice makes me sad. I can honor my patient's life by living a life worth living myself. So these look really different. I've read many of these over, the last several years since I started using these plans and talking to people about suicide postvention. Everybody's kind of mantra looks really different. But again, the idea is like helping yourself remember the things and regulate the things that you would want to if you found yourself in this boat. Okay, this last part down here, you're going to list your malpractice information or liability insurance, maybe some like legal teams, depending on how insurance works where you're at. When I was in private practice, I had like an attorney that I listed on there, my malpractice information, put the phone numbers down. Again, the less work that your frontal lobe has to do in this acute aftermath of the suicide, the better. So you want to put these numbers down so your brain doesn't have to do any heavy lifting at all afterwards. And then add any administrative things you need to do following a patient death. Most institutions have procedures that need to be followed, right? Like you have to notify your supervisor. The supervisor probably escalates and reports the suicide. There may be some kind of internal review, but whatever your role is, and this is something to chat about, as a unit, essentially, or a clinic or training facility of what do you want your folks to do after a suicide? What's their responsibility? To notify their supervisor? Anything beyond that? Have those conversations ahead of time and write it down on your plans so that even when you find yourself in this spot where you're just totally knocked on the ground by the grief and trauma and shock of one of your patients dying by suicide, you've got the whole plan. You know what you need to do next, who you need to call, who to reach out to if you want to talk to a therapist. You've got a list of kind of self-management strategies all ahead of time.
Dr. Cook,
Yeah.
something that came to mind here, a lot of us working with youth, where does the kind of conversation happen with the family, the parents? Maybe you're being told by the parent what happened. Had that happen on occasion? Um, and then what's kind of your sense on recommendations around funeral attendance, being part of the process with the
Yeah.
family through the grieving process for yourself as well as supporting them?
Yeah, broadly. Yeah, that's a good question. And, this is an area, again, where there's really a lot of, or not a lot of emerging research, but it's like a very new area where we're just starting to think, what are the ethical and legal considerations of talking to folks about a patient's suicide, even if it's other family members of the patients attending funerals. What I have seen is that in my circles of professionals and those that I have talked with is that providers are given the option, oftentimes by their institution, to attend the funerals and to talk with the families after a death like this has happened. There's a bit of variation that I've seen in what providers want to do. Some providers want nothing to do with attending the funeral of their patient, and then other providers, great providers I respect, have also attended the funeral. So I think there's a lot of variation. I think a couple big things to think about as we're making decisions in the aftermath is, one, what are our ethical obligations, right? The ethics of any particular situation. Am I doing good, or are there prospects for harm if I do attend? But the other side of it is the institutional demands as well. Some of us are limited, by procedures and policies that are already put in place in our institutions. So I would say, if your institution affords you the opportunity to attend the funeral and you would like to, and you've thought about it ethically and it seems like an okay idea, I don't see any problem with that. Yeah. It may even not be an option, I guess, to say on the other hand, too. With both of my suicide deaths, I never had any contact with the family, wasn't told of or invited to a funeral or anything like that. But I do know providers who have attended funerals.
Yeah, I think from our end, a lot of times the family is part of the patient you're providing for because they're all minors, or a lot of them are minors. So there's that added relationship. And I've found that
Right.
the times I've had to deal with this, that where I've had an ongoing relationship with the family for years, really contributed to decisions I made after the event versus, you saw the patient once and didn't really have much connection or something like that.
Right. Yeah. There's a lot of variations in scenarios of how it happens. Yeah. But I would say, as long as you're making ethical decisions and being conscious about those different factors and, abiding by the institutional demands of your organization, then I think, I don't think there's harm necessarily in attending those things or being more involved in some cases. Yeah. So this is what I've got for you today. Take it or leave it. You're welcome to fill out the postvention plan. I would encourage you to, even if you don't think you'll ever need it. I hope you don't. I truly hope you don't ever need it. But if you find yourself surprised like I was and put in a spot where you do need it, it would be nice to be able just to pull it up out of a file on your desktop and kind of walk through the different steps. So to wrap us up, suicide is common and will likely continue to be common throughout our careers. There's no indication that suicide is going away anytime soon. And it impacts us. It impacts us sometimes really greatly. And that's a normal thing. It doesn't say anything about your worth as a provider. And it's normal and healthy to talk about that with our field, within our field, outside of our field. And then planning ahead through this plan or any other means you can think of, really, but planning ahead and kind of processing ahead a little bit can help you build resilience afterwards, connect with other people, and manage the tragedy of losing someone to suicide if and when it does happen. So that's what I've got for you today. I have put my contact information up here, including my cell number. You're welcome to reach out if you have other questions, or even months or years down the road. If you find yourself in this boat and need someone to, lend an ear, you're welcome to reach out to me. I'd be happy to chat with any of you even down the road. Thoughts or questions that I can answer? Or
Dr. Cook, I found this really, really helpful. I feel like it isn't a topic that we talk about much, if ever, really. And it's kind of one of those, almost feels sort of taboo-ish, and it's nice to just shed
Right.
light on it and have it, not to like normalize it, I guess, isn't really, we don't ever hope for this to be something that happens very often, but it does feel normalizing to me. So I appreciate you.
Good. Yeah, you bet. I'm glad to hear that.
I also appreciate kind of the plan, not only for postvention for suicide, but I think is helpful for providers for us to complete just in general. We talk with our patients so much about self-care, but we're often not so great about enacting those things. And so even thinking through, if you're working with an outpatient for therapy and you think things are going well and they report suicidal ideation and you're bringing them for an evaluation, I think this plan is still helpful in those situations. And so I do think is something that would be helpful for us to definitely to fill out and to consider. So I appreciate you bringing this to our attention.
Yeah, totally. I like that idea because you're right. It isn't just patient suicide that impacts us, as providers. There's a variety of other patient interactions that can kind of send us spiraling from time to time. So, yeah, I agree. Could be helpful.
I wonder, Dr. Cook, thank you so much for this presentation. I wholeheartedly agree. This is a topic we probably ignore way more often than we should. I'm curious, when I think about other medical disciplines, I think, there are lots of other specialties where loss of patients is much more common than it is for us in child psychiatry, in particular. And I wonder if that's part of, I know it's part of why it is so impactful, I think, when we experience it as child psychiatrists. But are there ways to adapt, or can you suggest ways to adapt kind of this preparation sheet to maybe somebody who's dealing with loss much more frequently than we are? Like, how do we talk to, an ICU team about preparing for dealing with this, what becomes chronic loss almost for them? Any suggestions or thoughts or directions I could go on that?
Yeah, sure. Yeah, that's a great point. There are different specialties with higher rates. I would say first, the literature does suggest that those things aren't necessarily taken in stride, even when it is more common. Like we see quite high suicide rates among physicians in particular, in turn, because of some of the things that physicians are seeing and dealing with at higher frequencies. I would say, to adapt this, one of the things I would think about in other specialties where suicide rates are higher than our provider suicide rates are, is adding a section or thinking about your own warning signs. Like oftentimes we get so stuck as providers just in getting stuff done, right? Like doing our jobs and flying from thing to thing every day that we can miss our own warning signs of like when we are going underwater and things aren't going well. And so it can be helpful to write out warning signs. Like, how do I know when things are really not looking good for me? For me, it might be things like my car is messy. My car is never messy, right? So my car gets messier, or I'm not doing the dishes anymore. My dishes are piling up, or I stop responding to text messages from people, or I stop going to trivia on Wednesday nights, which I do every Wednesday night, some kind of tangible list of things, of kind of like warning signs. If I'm doing these things, I need to take a pause and think like, okay, things aren't going super well for me right now. And then using some of those mitigating steps afterwards. Another recommendation would be to put a bit more emphasis on the intervention side of things. So, maybe seeing the EAP or that therapist more regularly for people or for providers who have more chronic exposure to these types of things or more frequent exposure to these types of things.
Great. Thank you so much.
Yeah. Okay, I'm going to stop sharing this so I can see you all again. Any last questions or thoughts that I can answer?
Again, I'm really appreciative of you presenting today. I guess the only other thing I was thinking of is my mind's spinning ideas, but everybody has sort of a spiritual journey, worldview, and when we talk about death and things, that factors in how we interpret the finality of life ending, and so that may be another component to add in somewhere on the list in terms of how that informs each of us in its unique way when we're going through something like dealing with a death of a patient.
Yeah, totally. I agree. Something to think about and talk through more. I've got a little bit of that in the mantra of mine that I shared of just, I personally believe in people's autonomy to choose whether they live or whether they die. And, that's a bit of a spiritual belief of mine. And so that's kind of the way I've mixed it in. But yeah, you could see it in that part, or even the self-management strategies too. I imagine spirituality and religion could provide or, play a role in that area too, of things that people may or may not be doing in the aftermath based on their beliefs and how they're thinking about it. Yeah.
And I'll just share, I've had the experience of 3 patient suicide in my career, and where it was for sure suicide. And each time the family invited me to the visitation funeral, which was unexpected in a sense, because again, all the feelings we're having is like they probably aren't going to want me around, or you're going to blame me or something. But and I went every time and found it was really a healing process for all involved, myself included. If I'm not saying that's always how it goes. It's just been my experience.
Yeah, right. Absolutely. I think, I didn't attend any services for my 2, but the people that I do know that have said the same things, really positive things, that it was kind of cathartic and healing and provided some closure for both the provider and for the family too. Yeah.
And sort of oddly, they were appreciative of, hey, all the things you were doing and trying, and we know it was a struggle. And again, I think from our end, we were trying to see it as a failure in a sense. And so going through that experience sort of was a different lens they were using. Yep.
Yeah, it's a bit eye-opening. There is some research on that showing that family members tend to have a lot more positive views of us providers. And it's actually us providers, like you're saying, who are more worried, that we'll have the blame, or we didn't do enough, or the family will be upset. But the research doesn't suggest that. Families tend to be pretty gracious and grateful for the things that we were trying and doing, which is a different lens than many of us use.
Yeah. Thank you so much.
It may not be relevant every time, but I just feel like that speaks to the relationships you build with the parents. I mean, I'm just kind of talking back to Dr. Peters here, but for all of us, I mean, I think we want to just really think about how that impacts maybe an aftermath of something like this. I mean, we can try our best, and sometimes that relationship still may be difficult or a struggle, or parents may not have always seen our perspective on treatment or something an adolescent's doing, for instance. But yeah, it's interesting to think about that too. How we feel when our family members die, whether a medical doctor, we feel like they've done a good job, or, like whether we feel like they've had good bedside manner or not, even, like, did they make mistakes, but were they nice, did they feel connected to us? I think must a picture play a role.
Totally. Yeah. It's really, really complex, and like so many different things intertwine. Yeah, absolutely. Okay. Thank you. Well, if you have questions that come up later, as I mentioned, you've got my contact information. Happy to chat with any of you at any point down the road too. But thanks for having me today.
Thank you so much, Dr. Cook. We really appreciate your time.
You bet.
Thanks.
Have a good afternoon. I'm going to go get coffee now.
Thank you.
Bye-bye.